Hello, my name is Greg Naiman. I'm a practicing emergency physician in New Jersey. I am presenting response and amplification to Dr. Irvin's presentations on how to use a single ventilator to ventilate multiple patients in response to the COVID surge. So just a brief timeline to catch everybody up. In 2006, Dr. Irvin and myself published research that showed theoretically you could ventilate up to 4 patients, 4 adult males, on a single ventilator. And this was replicated in 2008 in sheep. And in 2017, Dr. Menes used my research in order to help Las Vegas shooting victims when they ran out of ventilators in his hospital. And now we're talking about it again because the COVID pandemic is concerning that it might exhaust our current ventilator supplies and ICU beds. And if there's a sharp peak, we might have patients dying because there aren't enough ventilators. Dr. Irvin has made a video, which I will link both in a card and also down there in the doobly-doo. And her video is on the nuts and bolts of how to put this setup together. So my purpose today is just a clarification on particular issues with using ventilators in patients with intrinsic lung disease, such as you have in COVID-19 pneumonia. So just to catch any lay people up who might be viewing this video, when do you use a ventilator? There are 2 broad categories. One, there's muscle paralysis, which causes a patient inability to breathe. This is most common when a patient has to undergo surgery and the patient is deliberately paralyzed for the surgery. Lou Gehrig's disease, everybody did the ice buckets a few years ago, can cause this, and botulism poisoning can cause this. The other more common reason to use a ventilator, especially in illness, is there's a problem inside the lungs that causes the patient difficulty oxygenating. That heart failure can cause the lungs to fill with fluid. Asthma can cause the airways to narrow and prevent air from getting in. And pneumonia, including COVID-19, can damage the lung lining and cause the fluid to leak. So how does a ventilator work? This is the normal vent setting where there's 1 vent and 1 patient. And this is in a can't breathe scenario. And as you can see, the lungs are totally clear on this patient. So oxygenated air goes into the patient through the tube that's in their trachea. And then it encounters normal lung resistance and it's able to fill the lungs properly. And then it's pulled out by the ventilator. The deoxygenated air is pulled out. At this point, the ventilator does a system check. It makes sure that all the pressures in the circuit are okay. And the reason is because if the pressure in the airflow is too high, that can actually cause lung damage. So the vent checks and says, okay. Now then, what happens in the scenario where the problem is in the lungs? As you can see, this guy has a lot of fluid in his lungs. So air goes in, encounters increased lung pressures, and then it goes back reporting to the ventilator high pressures. At this point, the physicians, the nurses, the respiratory therapists can tweak the machine to make sure that the patient is getting enough oxygen without causing an increased pressure in their lungs, which would cause lung damage. Now, this is my experimental setup. This is in 2 patients. I did just 2 patients for simplicity's sake, but ventilators can perhaps ventilate up to 4 people simultaneously. The same concepts apply. So first, the air goes in, and this is where their lungs are normal. The air goes in, And because they have normal lung resistance, the air comes out and the system check is okay. And more importantly, the patients themselves are not experiencing any harm. Now then, there's a much different story when it's two patients who can't oxygenate, because most likely, even though the patients have the same size lungs, this patient on the left has moderately bad pneumonia, and this patient on the right has severely bad pneumonia. And the issue is that even a pneumonia that starts moderate can progress to severe in the matter of hours. So it's a dynamic situation where you can't just leave the vent and expect it to work as you first set it. So what happens? So the airflow does not go as normal, and you can see the size of the arrows. What's happening is the patient on the left is getting too much air. It is being diverted from the patient on the right who has high pressures, so it's harder for the air to go into his lungs. So the air is preferentially going to the patient's on the left lungs. This is bad for two reasons. First of all, the patient on the left is getting increased airflow, and that's actually causing further lung injury to the patient. And the patient on the right also is having problems because the decreased airflow means that patient is not getting enough air. And here's the biggest problem. The ventilator system will not be able to know that anything is wrong because the same amount of air is going out and the same amount of air is coming back. So if clinicians who are accustomed to waiting for the ventilator to tell them when something is wrong, it will be too late. The patients will experience injury. So what do we do about this? So any patients that have pneumonia and are placed on a shared ventilator must be periodically reassessed for pressure mismatches. And how do you do that? I don't know. That's something that needs to be explored, most likely in the midst of deploying this technology. So even though you might have a 10-bed ICU and used to having 10 patients on vents, and now you've got a 10-bed ICU with 10 vents and 40 patients, your workload has increased 4 times, but you need to be even more vigilant with those patients than you were with the 10-bed ICU, which is very hard. You have to watch all 40 of those patients to look for pressure mismatches. And if there are pressure mismatches, you need to do musical ventilators and pair up patients or, cohort patients with other patients who have approximately the same lung resistance as they do. And if the lung resistance changes the next day, you need to play musical ventilators again. And once again, remember, the vent will not alarm. So we have to watch out with other techniques. My recommendation is right now, we need to develop inline methods for tracking either flow through the patient tubing to each individual patient or pressure, because we should not rely on the vent systems. And I don't know, this BVM gauge, I don't know if it can be adapted to be in line with a vent system, but something like this, where a quick visual inspection would show that during each breath, each patient is getting approximately the same amount of pressure through their system. And I'm going to end this with an appeal for research. If there's any researchers doing animal models at this time for ARDS, if some of the animals can be spared to do vent cohorting studies, if you can find unequal models where one animal has moderate damage and the other has severe, see what happens when they're placed on the vent, see if there's any signs and symptoms that can be tracked to show that there's ventilator mismatch going on. Finally, from my daughter, Yvette, who's 11 years old, she wants to thank you for all the hard work that you do, and we're all rooting for you.